Hello everyone, welcome to RAAONLINE. So in this fifth lesson in our nephrology module, we are going to learn about renal tubular acidosis, a very interesting topic, something which we can all easily understand if we just know the renal physiology. So as simple as that. So let's drive straight ahead. So what is this group of conditions which is referred to as renal tubular acidosis? So as the name itself suggests, there is a problem in the renal tubules, and as a result of that the patient develops metabolic acidosis. So whenever there is metabolic acidosis, that means either there is going to be decrease in bicarbonate. So that means the kidneys are not absorbing the bicarbonate well, and hence there is lot of bicarbonate loss, or the kidneys are not secreting the hydrogen ions well, and therefore there is a build up, an increase in the absorption of the hydrogen ions. So accordingly, here renal tubular acidosis is going to be predominantly made up of defects which either affect bicarbonate reabsorption. So what happens as a result of that? There is going to be excessive bicarbonate loss and the patient develops a metabolic acidosis. Or there are going to be defects which are going to affect the hydrogen ion secretion into the urine. As a result, there is a lot of hydrogen ion retention, and that is going to result again in metabolic acidosis. So all this, finally what happens? So we just saw that there is a problem. There is nothing that's too tough to be remembered here. So renal tubular acidosis, so a tubular problem which is going to result in metabolic acidosis. That means in the body the bicarbonate level should be low or the hydrogen ion level should be high. Therefore, when you look at the kidney, what is happening? There is a lot of bicarbonate loss in the urine. So that means there is defective bicarbonate reabsorption. Similarly, when you look at the hydrogen ion, what happens? There is defective hydrogen ion secretion in the urine, and therefore there is a lot of hydrogen ion retention, and both of this is going to result in a normal anion gap metabolic acidosis. And then what happens to the urine? Because in the urine normally H plus ions should be present. Here we just saw that the H plus secretion into the urine is going to be defective. So less H plus ions in the urine, and there is going to be bicarbonate loss in the urine because of defective renal bicarbonate reabsorption. Therefore, lot of bicarbonate in the urine. So this combination is going to result in an alkaline urine. So there is going to be rather impaired acidification of the urine. So decrease in acidification of urine, and these patients are going to have a normal anion gap metabolic acidosis. So because here purely the defect is either in hydrogen ion retention or it results in bicarbonate loss, you are only going to have a normal anion gap metabolic acidosis. There is no buildup of unmeasured osmoles like uremia or diabetic ketoacidosis, where all these unmeasured anions are going to be built up, and therefore you have this anion gap. That is not happening here in renal tubular acidosis. So these patients have a normal anion gap. Now what is the anion gap? Anion gap is the difference between the cations and anions, which tells you the amount of unmeasured anions that are present. Now this is going to be increased, as I said, in conditions where there is going to be excessive unmeasured anions, uremia, diabetic ketoacidosis, lactic acidosis, salicylate toxicity, all of this. So normally the anion gap is somewhere between 12 to 16 millimole per liter. If it is more than 20 millimole per liter, then definitely there is a high anion gap. So how do you calculate it? Sum of cations, which is sodium and potassium, minus the sum of anions, which is chloride and bicarbonate. This is how you calculate the anion gap. Now we have three major types of renal tubular acidosis. We have the distal renal tubular acidosis, which is called type 1 RTA. Here, as the name suggests, there is a problem in the distal tubule. Then we have the proximal renal tubular acidosis, which is type 2 RTA. Here again, as the name suggests, the problem is going to be there in the proximal tubule. And then we have type 4 renal tubular acidosis, which is a hyporeninemic hyperkalemic renal tubular acidosis. So whenever I say hyporeninemic, that means there is less activity of the aldosterone also. So where does the aldosterone act? It acts at the level of the collecting ducts. So this happens very distally. And remember, as the name itself suggests, this is the only renal tubular acidosis with an elevated potassium. In the former two types, the potassium level is going to be low. So let's try to understand one after another. We'll start off with type 1 renal tubular acidosis, which is also called distal renal tubular acidosis. Now first, this can be either primary, which could be because of a hereditary defect. So there could be mutations, say distal renal tubular acidosis. Before we look at primary and secondary, understand that there is a problem in the distal tubule, and distal tubule is very important for hydrogen secretion. So there is going to be a problem in the hydrogen secretion into the urine at the level of the distal tubule, and that is going to result in a lot of hydrogen ion retention, which is going to produce a normal anion gap metabolic acidosis. Now, primary distal renal tubular acidosis is an autosomal recessive, usually has an autosomal recessive inheritance because of mutations in A4 and B1 subunit genes of hydrogen ATPase. It can also be autosomal dominant, which is caused by mutations in the AE1 gene. So, basically the hydrogen pumps which are going to be there in the distal tubule, which are responsible for hydrogen secretion into the lumen, when there is going to be a mutation which makes these pumps defective, that is going to result in a hydrogen secretion defect, acid secretion defect in the distal tubule, and that is the cause for hereditary distal renal tubular acidosis. Now, secondary distal renal tubular acidosis, this is more common, this is acquired, usually seen in the context of drug use, particularly amphotericin B, lithium, very high doses of ibuprofen. It can also be associated with diseases like Sjogren's, SLE, primary sclerosing cholangitis, sickle cell anemia and Wilson's disease. So let's try to understand the pathophysiology in distal renal tubular acidosis. So what happens here? Here you are able to see we have the hydrogen ATPase and the hydrogen potassium ATPase, two very important pumps which play an important role in hydrogen ion secretion into the urine. So this takes place at the level of the type A alpha intercalated cells in the cortical collecting ducts. Now when there is going to be a defect in these pumps, that is going to result in an acid secretion defect. Similarly, in addition to this, there can also be that in patients with distal renal tubular acidosis, there is going to be an increased permeability to hydrogen ions. So that is going to result in hydrogen ion entry from the lumen into the cell. So both of these processes, defect at the level of the hydrogen and hydrogen potassium ATPase pumps, as well as an increased luminal permeability to hydrogen ions, both these are going to result in acid secretion defect and increase in acid retention, which contributes to normal anion gap metabolic acidosis. Now, this hydrogen retention is also going to decrease the renal calcium reabsorption. There's a lot of hydrogen here in the cell, right? This is a positive ion. So remember, the charge inside the cell plays a very important role in driving to and fro motions of all these ions. So when there is a lot of positive ions in the cell, other positive ions like calcium, they are preferentially going to be avoided from the cell. Therefore, what's going to happen? Buildup of a lot of hydrogen ions within the cell is not going to favor calcium reabsorption. Therefore, there is going to be increase in calcium loss in the urine. This is what results in hypercalciuria that we see in distal renal tubular acidosis, and that is what contributes to nephrocalcinosis and nephrolithiasis. So why does hypokalemia occur in distal renal tubular acidosis? We understood why acidosis occurs, we understood why hypercalciuria occurs, but why does hypokalemia occur? So what happens? Basically all this decrease in hydrogen ion secretion and increase in hydrogen ion retention results in acidosis, and overall acidosis is going to reduce the net proximal tubular fluid reabsorption. That is going to result in volume contraction. Now once there is volume contraction, which system gets activated? It is the RAAS system which gets activated, and when RAAS system gets activated, we all know that is going to result in hypokalemia. So this is why both in distal and in proximal renal tubular acidosis, the acidosis induced proximal tubular fluid reabsorption, which is going to be defective or rather reduced. So basically acidosis is going to have a significant bearing on the proximal renal tubular reabsorption. Now once that's defective, that means there is going to be a relative volume contraction, and that is going to stimulate the RAAS system. Once RAAS system gets stimulated, there is going to be hypokalemia. So three major features that are important in patients with distal renal tubular acidosis. What is that? One is there is going to be an acid secretion defect. This is going to result in a relatively alkaline urine. So, the urine pH is going to be above 5.5, and because of an acid secretion defect, these patients are going to have metabolic acidosis. What kind of metabolic acidosis? A normal anion gap metabolic acidosis. Then what happens? What is the second defect that we saw? We saw that this excessive retention of hydrogen ions, it will not favor calcium reabsorption into the kidneys. Therefore, there is going to be an excessive calcium loss in the urine. Hypercalciuria along with hypocitraturia is going to predispose to nephrolithiasis and nephrocalcinosis. And then what happens? All this acidosis is going to reduce the proximal tubular reabsorption, and that is going to result in volume contraction, which stimulates the RAS system, which causes hypokalemia. So, urine pH is going to be relatively alkaline, there is going to be a normal anion gap metabolic acidosis, there is going to be hypokalemia, and there is going to be nephrolithiasis and nephrocalcinosis. What is the difference between these two terms? Nephrolithiasis means there is a simple renal stone. Here you are able to see, right? So, all the calcium oxalate stones are usually radio opaque stones. So, it is visible as a single calculus on the X-ray. Now, nephrocalcinosis means there is calcium deposits in the renal parenchyma, in the interstitium. So, this is how it looks like on the X-ray. So, both these can be seen in patients with distal renal tubular acidosis. Now, having understood the basics of distal renal tubular acidosis, let's quickly move on to proximal renal tubular acidosis so that we will understand how this is different from distal renal tubular acidosis. Now, just like how with distal renal tubular acidosis, we saw that there were a couple of drugs and diseases which caused a secondary distal renal tubular acidosis, and then there was a hereditary defect which caused a primary distal renal tubular acidosis. Here again, primary proximal renal tubular acidosis is because of a mutation. Now, before we understand primary proximal renal tubular acidosis and Fanconis syndrome, here again it is important to understand that in primary renal tubular acidosis, the problem is in bicarbonate reabsorption. So, how I remember it is like this, A, B. So, A is 1. So, type 1 renal tubular acidosis, there is a defect in the acid secretion. A for acid secretion defect, type 1 renal tubular acidosis. And where does the bulk of acid secretion take place? In the distal tubule. Therefore, this is the distal renal tubular acidosis. Now, bulk of the bicarbonate absorption, B for bicarbonate. A bulk of the bicarbonate absorption, almost 90% of bicarbonate absorption happens in proximal renal tubules. So, defective bicarbonate reabsorption, which is going to bring about increased bicarbonate loss in the urine, is going to result in type 2 renal tubular acidosis, which is called proximal renal tubular acidosis. Now, therefore, here what are the defects that can cause a primary hereditary proximal renal tubular acidosis? If there is going to be a mutation in the gene which encodes the sodium bicarbonate, the transporter, sodium bicarbonate co-transporter, then that is going to result in primary proximal renal tubular acidosis. Now, although bulk of the bicarbonate reabsorption actually happens from the lumen into the cell through this enzyme which is called carbonic anhydrase, from the cell it gets reabsorbed back into the system through this sodium bicarbonate exchanger, through this sodium bicarbonate co-transporter. Now, acquired proximal renal tubular acidosis can be seen whenever this crucial enzyme which plays a huge role in bicarbonate reabsorption, when this is blocked. So, when a patient is going to be on a carbonic anhydrase inhibitor like acetazolamide, that is going to sort of create a picture very similar to proximal renal tubular acidosis. Only thing here, it is a drug which is causing the defect by directly inhibiting the enzyme which plays a key role in proximal renal tubular bicarbonate reabsorption. So, remember, acetazolamide and other carbonic anhydrase inhibitors can cause an acquired form of proximal renal tubular acidosis. In addition, you have a hereditary form because of a mutation in the sodium bicarbonate co-transporter. And then you have Fanconis syndrome. What is Fanconis syndrome? Fanconis syndrome is basically you have a widespread proximal renal tubular dysfunction. So, how is it different from primary proximal renal tubular acidosis? Here we saw that there was a defect only with respect to the bicarbonate reabsorption, whereas here in Fanconis syndrome, there is a diffuse proximal renal tubular defect. So, you would already know that the proximal renal tubule plays a very important role not only in bicarbonate reabsorption, it also plays an important role in the reabsorption of sodium, in the reabsorption of water, in the reabsorption of amino acids, in the reabsorption of uric acid, glucose, phosphate. So all this is hit. So there is a diffuse proximal renal tubular dysfunction, and the features of normal anion gap metabolic acidosis, which occurs in proximal renal tubular acidosis, are going to occur along with a lot of other abnormalities which will reflect a widespread proximal tubular dysfunction. So there is a loss of phosphate, there is a loss of glucose, defective absorption of uric acid, amino acid, low molecular weight proteins. So eventually what happens? The patient develops hypophosphatemia, hypouricemia, amino aciduria, glucosuria, and all this hypophosphatemia can result in osteomalacia. There can also be a deficiency of the active form of vitamin D, which is 1,25-dihydroxy vitamin D, because of impaired conversion to this 1-alpha form in the proximal tubule. Now, what is the most common cause of this Fanconi syndrome, which is a widespread proximal tubular dysfunction in adults, which is the most common cause? It is going to be multiple myeloma. In addition to myeloma, other inherited disorders like cystinosis, tyrosinemia, Lowe syndrome, galactosemia, and drugs like ifosfamide can also cause Fanconi syndrome. So as far as proximal renal tubular acidosis is concerned, two major things that you should think of other than the hereditary causes. One is the patient on a carbonic anhydrase inhibitor. Two, if there are other features suggestive of a widespread proximal renal tubular dysfunction, could this be multiple myeloma? These are the two questions which you should answer. Now let's try to understand a little bit about the pathophysiology here. So here you are able to see at the single glance, you are able to see how much of an important role the proximal tubule plays in the reabsorption of a lot of molecules. You are able to say that phosphate, glucose, amino acids all get reabsorbed thanks to secondary active transport by means of these sodium based cotransporters. Similarly, here you are able to see that proximal tubule also plays an important role in acid secretion, and it plays a very important role in bicarbonate reabsorption. So this bicarbonate is reabsorbed through carbonic anhydrase mediated mechanism, and the reabsorbed bicarbonate, what happens? It is further absorbed back into the interstitium from the proximal tubular cell through this sodium bicarbonate cotransporter, and a mutation in this transporter is what is going to result in a primary proximal renal tubular acidosis. When you use carbonic anhydrase inhibitors like acetazolamide, it is this step which is defective, and hence there is a defective bicarbonate reabsorption. Now, these patients overall are going to have defective bicarbonate reabsorption. So, there is an increased bicarbonate loss in the urine, and therefore what happens? They develop a normal anion gap metabolic acidosis. So, in primary proximal renal tubular acidosis, this is where the defect is going to be in. So, there is going to be a mutation in the sodium bicarbonate cotransporter, and in patients who are on carbonic anhydrase inhibitor, this step goes chaotic. So, this step is blocked, and therefore, there is going to be impaired bicarbonate reabsorption. So, overall, this defect in bicarbonate reabsorption is what plays an important role in making the urine less acidic and contributing to this normal anion gap metabolic acidosis. Now, this process of bicarbonate reabsorption itself is actually a saturable process. What does that mean? So, that means that if the serum bicarbonate exceeds beyond 25 milliequivalent per liter, usually these processes get saturated. They automatically get blocked even under normal circumstances. So, here what happens in patients with proximal renal tubular acidosis, this threshold is actually going to be reset. So, the threshold for bicarbonate reabsorption, which was set at, let's say, 25 milliequivalent per liter. So, any bicarb less than 25 milliequivalent per liter, these bicarbonate reabsorptive mechanisms are going to be active. The moment serum bicarb builds up to above 25, then these mechanisms are going to be blocked. Now, what happens? In patients with renal tubular acidosis, this threshold is lowered. So, for example, instead of 25 milliequivalent per liter, this threshold has been brought down to 16 to 20 milliequivalent per liter. What does that mean? That means when the bicarbonate is as low as 16 or 17, even at that point, these bicarbonate reabsorbing mechanisms will still be blocked, because now the threshold for reabsorption is at 16. So anything less than 16, then these mechanisms become active, but anything more than 16, these mechanisms will be blocked. So whenever the serum bicarbonate drops to less than 16, then what happens? At that point, these mechanisms become active. This block is reversed and the patients are capable of bicarbonate reabsorption, and hence the urine is going to become acidic once again. So this tells you that unlike distal renal tubular acidosis, in proximal renal tubular acidosis, the defect is dynamic, because you have a particular threshold, and these bicarbonate reabsorption, because it is a saturable process, once that threshold is hit, beyond that there is going to be bicarbonate reabsorption which normally occurs. This is what happens. So that tells us that initially what happens, as long as the serum bicarbonate is going to be somewhere around 20 to 24, the patient's bicarbonate reabsorbing mechanisms will be blocked, and therefore the patient will be passing an alkaline urine. When you look at the urine pH, it will be more than 5.5. But when you look at a lower level of bicarb, now as this progresses and as there is more bicarbonate loss, the bicarbonate level drops further. Suppose the bicarb is only 14. At this point, this block gets reversed. Now these mechanisms again become active. There is going to be bicarbonate reabsorption, and therefore the bicarbonate, because of reabsorption, increases to 16, and the urine pH is going to be less than 5.5 at this point. So knowing this is very, very important. Why? Because usually when you suspect a patient with proximal renal tubular acidosis, you are going to expect an alkaline pH and you look at the pH. But sometimes remember, deceptively your pH may be normal. You may have an acidic pH. In that case, you go back and look at the bicarbonate. If the bicarbonate is relatively lower, then that explains why this pH is become acidic, right? Because of this process. Now similarly, at higher levels of bicarbonate, you are going to have an alkaline urine, and at lower levels of bicarbonate, the urinary pH is going to be relatively more acidic. And because of this mechanism, in proximal renal tubular acidosis, your bicarbonate is usually above 16. It is never 16, because the moment it drops below 16, the bicarbonate reabsorbing mechanisms are going to become active, going to reabsorb bicarbonate and push its level back to above 16. So usually in proximal renal tubular acidosis, the urinary pH may be variable, and that's going to depend on the serum bicarbonate. Higher bicarbonate level are going to be associated with an alkaline urine, and lower bicarbonate level are going to be associated with a relatively acidic urine. And when you look at the bicarbonate, it is usually reduced but not lower than 16 usually. And similar to what we saw earlier with distal renal tubular acidosis, here again the acidosis is going to reduce the proximal renal tubular absorption. That causes volume contraction, that is going to stimulate the RAS system, and that is going to create hypokalemia. So let's look at the clinical features. Keeping in mind all the abnormalities in proximal renal tubular acidosis, there is a bicarbonate reabsorption defect, and therefore the urine is going to be less acidic, because there is going to be a lot of bicarbonate which is lost in the urine. So however, because of the mechanisms we just discussed, the urinary pH is not always above 5.5, unlike distal renal tubular acidosis. So the urine pH can be variable, and you usually find that with lower levels of bicarbonate, the pH is also lower. Remember that. Here again there is going to be metabolic acidosis, a normal anion gap metabolic acidosis because of a defect in the bicarbonate reabsorption. There is going to be hypokalemia, which can cause muscle weakness. The hypokalemia is because of RAS activation. And when there is widespread proximal renal tubular dysfunction, when the proximal RTA occurs as part of Fanconis syndrome, that is going to result in hypophosphatemia, hypouricemia, a euglycemic glycosuria, and proteinuria. So euglycemic glycosuria means there is glucose in the urine, but you will find that the blood glucose levels are normal. This is in striking contrast with diabetic patients, where it is the hyperglycemia that causes the glycosuria. So whenever you have this picture of a euglycemic glycosuria, think of a proximal renal tubular dysfunction. So when you look at the fractional excretion of bicarbonate, so how do you calculate the fractional excretion of bicarbonate? Urine bicarbonate divided by plasma bicarbonate into plasma creat by urine creat. This is how you calculate the into 100. This is the fractional excretion of bicarbonate. Now, fractional excretion of bicarbonate normally is less than 5%. Why? Because more than 90% of bicarbonate gets reabsorbed in the proximal tubule. But here what happens, because that precise process is going to be defective, the fractional excretion of bicarbonate is going to increase. It's usually more than 15% in patients with proximal renal tubular acidosis, and in patients with Fanconis syndrome there is going to be hypophosphatemia and hypouricemia. Now let's move on to understand about hyperkalemic renal tubular acidosis. This is also called type 4 renal tubular acidosis. Now, as the term suggests, this is because of a reduction in hydrogen and potassium excretion which happens at the level of the cortical collecting duct. Now, either there can be a selective aldosterone deficiency. Now, we know aldosterone plays a very important role in driving potassium secretion at the level of cortical collecting duct. Now, there could be a problem in this aldosterone, or there could be a problem in the kidney which is going to make this process, this potassium excretion, potassium secretion defective. So, what are these defects which can cause resistance, relative resistance to aldosterone action at the level of the cortical collecting duct? You have diseases which can cause chronic interstitial fibrosis like diabetic kidney disease, chronic kidney disease, lupus nephritis and obstructive uropathies, which can all cause a relative resistance to the action of aldosterone at the level of the cortical collecting duct. Therefore, there is going to be a defective potassium secretion. Now, in addition, this principal cell sodium reabsorption which happens through this ENaC channel, this again is going to be reduced, and this is going to reduce the transepithelial cell voltage. So, what does that mean? This ENaC's function is very, very important to drive this potassium outside. Now, this ENaC channel, the epithelial sodium channel, which is also the site of action of diuretics like amiloride, which is also under the control of aldosterone. When this does not act, either primarily because of a problem in the cortical collecting duct or a problem in the channel, or because of a problem with aldosterone, then what happens? There is decreased sodium inside the cell. Now, there needs to be increased sodium in the cell to push this potassium out. When there is decreased sodium, what happens? This gradient is lost, and therefore, the driving force, the primary driving force for this potassium channel is lost, for this potassium secretion is lost, and as a result there is going to be potassium retention. So, either there could be a problem in aldosterone, or there could be a problem in the collecting duct, or there could be a problem in the ENaC channel. All of this is going to result in potassium retention and hydrogen ion retention. And what happens? This potassium retention, it is going to reduce the ammonia production in the proximal tubule. And when it reduces the ammonia production in proximal tubule, we know that at the level of proximal tubule, the hydrogen secretion, the acid secretion happens through two predominant forms. One is, it is going to be dependent on ammonia, which is majorly produced by glutamine metabolism in the proximal tubular cells, and the second is this hydrogen ion is going to be trapped in the form of these hydrogen phosphate ions. It is going to combine with hydrogen phosphate ions to form phosphoric acid. So, these are the two major forms in which the hydrogen ion is trapped and acid is secreted at the level of proximal tubule. So, one is hydrogen ion is trapped along with ammonia to form an ammonium ion which gets excreted in the urine. Second thing is the hydrogen ion which is secreted at the proximal tubule is trapped by combining with hydrogen phosphate ions, and that is going to form phosphoric acid which is again secreted in the urine. Now, what happens? This hyperkalemia is going to actually reduce the amount of ammonia which is formed at the proximal tubule. Therefore, that is going to create a problem for hydrogen secretion. So, this is how this hyperkalemic, hyporeninemic renal tubular acidosis develops. So, actually, if you see, there is a problem with potassium secretion at the level of the cortical collecting duct in the principal cell. So, some defect either in the kidney because of a lupus nephritis, obstructive uropathy, diabetic kidney disease or a CKD, or problem with aldosterone or a ENaC channel. So, overall what happens? The potassium secretion at the level of cortical collecting duct is defective. Now, once this potassium secretion is defective, that means there is going to be hyperkalemia, and this hyperkalemia is going to impede or rather obstruct the glutamine metabolism. It is going to interfere with ammonia formation in the proximal tubule, and ammonia is very, very important for hydrogen ion secretion. So indirectly, all this potassium retention is going to impair hydrogen ion secretion at proximal tubule, and that is going to result in acidosis. So this is the major problem here.